And a tail of bones. You'll notice the bones are out. Hey, who doesn't like bones? I like bones. All right. So effectively, this is somewhat of an introduction, maybe a little bit more regard to bones and bony anatomy more so. I'll pretty much skip the physiological aspects of it, and we'll address that in lecture when we're done with the skin. So as I try to sort of marry the two units, uh, the bone physiology and the bone anatomy. So and we'll go over the exceptions, but by and large, most of our bones come from a cartilaginous shell. And that cartilage is hyaline cartilage, which sort of builds on our basis in various kinds of connective tissues. So, as you can see, it's by and large, it's replaced by bone. It's the skeleton, if you can imagine, in a neonatal environment, in a fetal environment, how there's an inherent amount of flexibility that eventually gets placed by degrees of rigidity over time. So, the principal skeletal cartilage is all hyaline cartilage. Okay, it's again, the vast majority is of water. It doesn't have blood vessels or nerves. Indeed, what you're going to see as we get into the physiology, with the transition to bone from that shell is brought on by invasion by blood vessels more than anything else. Bone and cartilage to start has a layer of dense connective tissue and really a girdle, anything that surrounds it, a sleeve, whatever works for you is really and it's such an important tissue. It's called perichondrium, and down the road you're going to see it's called periosteum as it makes the transition from cartilage to bone. That's where the new cells come from. That's where the nutrients come from. That's such a vital tissue, particularly when it makes the transition to bone. Cartilage, as we know, has those chondrocytes. The matrix itself is jelly, but a very firm jelly. Again, the cavities to me are more optical illusion than anything else. So it's really hyaline cartilage more than anything else without going into a lot of detail. And this unit will probably talk more about fibrocartilage and perhaps not so much yet about elastic cartilage. It's all a matter of how they're put together. And you can go back and look at the cartilage part, which is in the 4B PowerPoint. But hyaline is by far and away the most abundant, and we're going to see it in the companion to this unit when we get to joints, articular cartilage, kind of what the cartilage that's left after the bone ossifies or becomes bone. The ribs, which we look at in this unit a bit, costal cartilage, not respiratory, that's later in the term, and not nasal, because really I look at that in respiratory. Again, the elastic, very limited examples, the epiglottis, which again is respiratory, in the ear, which really isn't, there's not a whole lot to say about it. We'll do it a little bit, just a tad about it in special senses. And fibrocartilage, okay, is the one that we will look at because we see it not only in the knee, but particularly and more abundantly in intervertebral discs. It plays a very significant role in the bone and joint related unit. So really, it's a spacer. It adds depth, it adds shape, and it's really pivotal. And hey, look, it's the good news and bad news about the start of the NFL season. Okay, it's when you're doing a course in anatomy, physiology with bones and joints. This is every week you have a new example, particularly early in the season. You have new examples of interesting material to talk about. Okay, the bad news is sometimes your best players, read that as TJ Watt, are going to be out for a while. Which brings to mind I've been watching Steeler games for the last 62 years. Okay, I haven't seen one like that ever. It's a lot of years. Oh, but I'm happy the Bengals still periodically become the Bungles. But if Watt's out for eight weeks, or His brother was out for 2 months with that likely injury. Okay, a pectoralis major tear, because it's kind of like from here and it starts into your humerus there. So I mean, you get the football players, they get pushed back like that's kind of how it tears. And so it's not an unusual injury in that regard, but it's 2 months is very rare that anybody comes back that soon. I digress. And as you see in this chart, or you will see it again, in the green is the elastic cartilage. They have it in different colors, and this one is red. That is the intervertebral disc. You can just see those little red lines. And the blue, everywhere else, hyaline cartilage. And bone and cartilage grow the same way, in the sense that appositional growth versus interstitial growth. Appositional growth, think of it as side to side in shape, widening and shape definitions. Okay, it's along the sides of this cartilage frame. Where interstitial, think elongation. And we explore this in much more detail in bone. We look at how the zones of cartilage effectively, where the bone is elongating, which you might know, though it's not its formal name, is called a growth plate. The fancy name you will come to know is called the epiphyseal plate. But everybody calls it the growth plate, and there's a certain interchangeability with those terms. So you're going to see, and bone does the same thing. Appositional growth, or the shape change that your bones, particularly once you reach maturity, your bones don't necessarily lengthen anymore, but they may widen or alter, depend on whether you're very active, whether you're comparatively inactive as you age, etc. Okay? So calcification of cartilage is normal for growing bone, but in old age, it's not the same as hardened cartilage. That would be more damaged or diseased cartilage. But what does happen, and unfortunately it happens with some degree of frequency, is that as we get older, your bone makes a transition, your cartilage makes a transition where there's more bone within it, normally. And it doesn't have the flexibility or the give. And that does limit the activities as we reach into our, I hate to say it, golden years. You should have seen me Saturday night after running around with a 2 and a 5-year-old for the 3 previous days. For those of you who don't have children, you wouldn't necessarily understand that. Ugh. So, support is obvious. Support, yeah. Protection, yeah. Something for the muscles to grab onto and move, yeah. Minerals and growth factors, a lot. Bone is very much, one of its principal functions is a bank, particularly for calcium, to a lesser extent phosphorus, and a variety of growth factors. So bone plays a very important role in all of these. Blood formation, though we deal with this much more in the chapter on blood, that's what makes red bone marrow red bone marrow. The way that term is expressed is called hematopoiesis. That's blood formation. And when we're young, it's in very much almost all of our bones. As we get to bone maturity, as our bones finally stop growing, relatively speaking in early adulthood or late teen years, then you're going to start to see that the long bones, and you'll come to see the extremity bones, no longer do that other than in very limited areas. They are then replaced, that red bone marrow with blood cell is replaced by fatty bone marrow called yellow bone marrow. So I don't think it's a big energy source, to tell you the truth. I mean, can you make the argument that it is? Yeah, but I'm sure it's not one of its major functions for energy storage. Okay? And then there's a hormone called osteocalcin that regulates, to some extent, insulin and glucose and metabolic levels. It's not one that we commonly look at. When we get to endocrine, I'll probably give you some more information. That's something we do in physiology. So I'm asked continuously by students, whether it's anatomy and physiology or these advanced courses, how do I study, how do I memorize these things? You memorize things by putting them together, almost compartmentalizing, by organizing the data. So the first thing you do is what bones are associated with your core, your head, neck, torso, and which ones are your extremities. That's the definition of axial, the long axis of your body, head, skull, vertebral column, rib cage. That's it. Sternum is part of that because it's really what the ribs indirectly attached to. And then the appendicular skeleton is your appendages, arms and legs. By definition, the girdles, and that's the term we give to the shoulder and the hip assembly, respectively, the pectoral girdle, should be easy to remember with the TJ Watt injury. We have a pectoral major, with pectoralis major tear, the pectoral girdle associated with this portion of your body, and what's called the pelvic girdle, and that should be fairly easy. So those, by definition, are considered part, they're associated more with the appendages, and they're really the attachment points, which you might surprise you aren't that really substantial, particularly when you look at the pectoral girdle area, the shoulder. Your upper extremity is attached in one spot. All you do is move yourself around like that and feel over here at the top of your sternum where that bump is, where the clavicle attaches. That's the lone attachment for either side of your extremity. Everything else that secures it is muscle. It's not bone to bone. The bone to bone attachment is much more substantial in your hip region, where there's a fairly large roughened surface called the auricular, because it looks like an ear surface that's on the sacrum, and it's on the part of the hip assembly, which is the ilium bone. And so we call it our sacroiliac joint. Okay, and you might hear somebody, older relatives, go, "Oh, my sacroiliac's killing me," and you know that because that's the term that they used associated with it. So again, we're seeing the same thing with the cartilage, same illustration, why bother? Now we get into bone classification. It's not about size, it's about shape. The first thing to remember is all based on shape. Most of the studying we do is based on long bones. They're longer than they're wide. It's humor. Okay? But if you want to see another long bone, it isn't very long. Here's for baby Joe. There it is. Not very long. But it's a long bone. It's longer than it's wide. Whether it's your pinky, tip of your pinky, or whether it's here, or whether it's here, or whether it's fibula, it doesn't matter. They're long bones. They're longer than they're wide. And when we study growth plates, when we study how bones grow, when we study the anatomy of the cortical bone and how it repairs itself, the reference point is long bones. Okay? They're really they're the strong one structure. You want to think of it that way. Longer than they're wide, and almost any limb bone, with some limited exceptions. The patella is not. The patella, your kneecap, is a short bone. Don't make fun of it. You're short. I wouldn't do that. These are pretty old bones. I mean, Dr. Drescher only named what these, but they started to do the anatomy and physiology of you. Some other school. I mean, that's patella. It's a short bone. It's short, not just because of this. It's not longer than it's wide. But they're typically cubical shaped, and really the hallmark area where we see them is your wrists and ankles. So here is a wonderful model that I use all the time. It's got 8 little bones that make up your true wrist, cartilage bones. They're short. They're sort of cubic in shape, more or less. So you get bone and you have a lot of size, at least 6, typical cubic, and has cartilage on each of those. So it's good news and bad news. Good news is there's a lot of cartilage, so you can generate a lot of moves of sliding and gliding motion. So you can do all sorts of stuff with it. It's good news. Bad news is what it is. Because those are bones that have typically all that cartilage was damaged. Blood gets into it, like the fracture, you get a lot of blood flows. That's the start. So the cubic, wrist, and ankle. The difference is that with the patella or kneecap is a sesamoid bone. A sesamoid bone forms either muscle or a tendon and actually kind of forms there and acts to enhance the leverage. So the knee is classic, it really allows you to extend your leg upon your thigh as anyone can walk. Okay? So you can walk for any reason. There's other sesame bones that are, you have a couple, like two little focus at the base of your big toe. Sesame bones, they form in a muscle, flexor lucis brevis. Down the road, we'll get to that. And so there's a certain amount of variation. Those are the ones we have. Sure. So you could not have one, sure. Okay, you take out a patella that's broken, sure. Sesame bone, not taking out numbers. Okay? See, I mean, sometimes they take them out because there's a reason to take them out. Mechanical function or fracture disease, things like that. But so it's not so much that there's extra bone, but interestingly enough, you have extra bones. Okay? So they vary in size and number. Flat bones and irregular bones. Flat bones are interesting. The skull, the scapula, the ribs, the sternum, because they don't necessarily form from a cartilaginous shell. Okay? Certainly, some of the skull bones do not. It's a different kind of bone growth. Okay? It's almost like the fibrous material, and all of a sudden the bone starts to grow in the middle. Really don't know why that occurs, but it does. Okay, it's not necessarily from a cartilage itself. Interestingly, those are the bones that are thin, flat, slightly curved. So you can tell the difference. Maybe I have one in. This is a rib. This curve, this is a plastic rib. That's a real rib. This is a real rib. Okay? Things like that. So it differs between a bone, let's say, that comes from cartilage. I could have said something else about there's a real collarbone. I mean, there's a lot of similarities. They're short, they look a little bit the same, obviously got a lot more curvature, but this is an axial bone, it's a rib, it's a flat bone. Yeah, you know, the clavicle really is not a collarbone. That's really got more along the lines of long bone. You know? Okay, and this is, by definition, even though it's right over here, since before it's appendicular. This is part of the assembly called the pectoral verb. It's the strut that helps your scapula, your shoulder assembly, either. And lastly, and it's almost obviously, intuitively, that they're irregular. Just look at it. You're an irregular bone. That is a vertebrae. Now, next time we meet, most likely we'll be able to know why I know this is a lumbar vertebrae. They're large, it's a good way to start. It happens because they have a square, sort of a square, this is called the spinous process, where the name spine comes from. It's called the spinous process, and it's flat. It's sort of like an axiom, or like almost like an axe shape type of thing, an axe blade shape. It's very distinctive, and look at that a lot. And we also look at the sets. The sets are those little areas where it articulates that views, where it forms a joint with something else. I could do bones in my sleep on my worst day. Been doing them for 50 years. Knee diagrams, all that stuff. I mean, I can't even tell you how many times I've done the bone motion. And more coming. That's why I get excited with bones. You'll find that, and you see that with every one of your professors, and you guys are experienced students now. Okay? Professors, you can always tell when they're more comfortable with subject matter, or something they know well. I know a lot about bones. If they let me operate on them, I should. Not anymore. I want nothing to do with that stuff. The guy who got married, there's a place in Jacksonville where it's like House of Shaves. Go figure. So they were shaving him. The ladies shaving him with like a straight razor, like your grandpa had, or my grandpa had. And he goes, she's never an exciting thing for somebody coming out with a sharp object. That was one of the good things with patients. I always had very steady hands. So she was a little jittery. I'm like, oh, great. And they wanted me to have one. So, are you kidding me? You're the one getting married. I've already done that twice. Not again. Not the same time. So here are the examples: a humerus, a vertebrae, a sternum, which I didn't grab. I grabbed the rib, and a short bone. This interesting bone's right down here. It's called the talus. That's your true ankle bone. Your tibia and your fibula articulate with it and sit kind of on top of it. Okay, so we call it osseous tissue. Has nerves, cartilage, connective tissue, muscles attached, liners from blood vessels. And we study all the different. I'm not going to go into that. That's lecture stuff and periosteum and all these neat things. That's a great illustration, by the way. That's called the trabecular pattern. That's something we really look at. And if you look at some of the real bone specimens, you're going to see that, because we have real bones wear down a lot. And ours are pretty old. They're very expensive while we haven't replaced them. But this would be healthy bone. If this was moth-eaten and disappearing and looks worse, that's really what osteoporotic bone looks like. And this is more physiology and more. And we are going to do all that stuff. That's really important. So the reason I'm zipping through that is for this. The anatomy part of the program deals, it's not just enough for you and I to pick this out and go, oh, there's humerus. Well, it's got a head, okay? It's got tubercles, which are over here. It's got a tuberosity that's over here. It's got named areas for articulation, joints, your forearm bones, the radius and all of that. That's right. You get to know all those things. No extra charge. You're excited. Okay. So those are bone markings. That's one of those things where muscles and ligaments and tendons attach. They pull and tug. Bone, this is the universal factor of bone. Okay. Wolff's law. Bone grows as to the forces on it, or acting on it, acting upon it. So, what's Wolff's law? You're pulling and tugging. So if you have the Achilles tendon pulling and tugging on the back of your heel, it forms what's a big round margin called the calcaneal tuberosity. Pulling and tugging on it. If you didn't have Achilles tendon, or if you were, heaven forbid, if you were paralyzed, if you couldn't walk anymore, if you were bedridden completely, what would happen is this would literally start to almost disappear in the sense of, it's rounded, it would undergo a process called atrophy. Because this forces you right there. Bone remodels continues. So it's a very, very interesting phenomenon, and one of the centerpieces of the bone. That's how we can tell that they were almost in a forensic sense if someone was acting, someone who recently died and was found in the names, where they athletically oriented, they have little fractures, and that's very, very important. So, areas involved in joint formation also are noteworthy, and the areas where blood vessels sit on the bone, penetrate the bone, or other structures like nerves do the same thing. They create a whole different substance. So you have three things that are categories of bone markings. One that basically protrude, ones that are hollows or holes, and ones that act as joints. Those are coming up now. So projections, surfaces, and depressions are openings. That's the three types. So we'll start with these, and I should be able to find illustrations of these. And what's important is, so typically from an exam perspective, for instance, this is a hip bone. Okay? It actually is three bones in one. So I have some tape and some letters, so you might have to know that this is on your rear end. This is called the acetabulum. It's a giant socket, which sits in that giant socket. It's the head of the femur. Okay, that's a socket. Your mom said, show me a ball joint with a socket. That's perfect ball socket, but that's it. Can't miss it. But that's the most important. Then the femur, the acetabulum. Up here, David is going to the ilium. This ridge area is called the iliac crest. Hands on your hip, it's up there. So crest forms with the structures that attach to most of the 4 acres small. And then what's neat about this is a regular bone. This is mostly black bone. So but we have bone blood formation here, a lot of red bone marrow, even as an adult. So this is where you would take bone marrow for say a bone marrow transplant. It's pretty close to the surface, that makes it easier to thumb it. You have a little incision, basically punch a hole in the bone, something called a trocar, and so that it's not so simplistic, it's not so difficult. Here to speak. I mean, obviously, if you're doing it for transplant purposes, you would have to do that, in an operating room environment. They do bone marrow aspirations bedside, check for anemia. We look at that aspect of things in physiology. I do the blood aspect. So, tuberosities. I just showed you one on the calcaneus. I showed you another one on the ischium, because this is the ilium, this is the ischium, this is a pubis. All three of them contribute to this indentation formed by the head of the femur called the acetabulum. So that's tuberosities. The crest I just showed you. Muscles attached form that ridged area. That's the iliac crest. And we utilize, these are aspects of surface anatomy that you can keep some effort depending on how heavy somebody is getting out of stage. Your femur is interesting, has two items that we see nowhere else. Right here, they're called trochanters, large, blunt, regularly shaped processes. Process projection of bone. This is larger and higher, it's called greater. This is the lesser. The only place we have greater and lesser, the only place you're going to find trochanters on the femur. They're a really important landmark called this area, the line in between them, intertrochanter and one. So the way we classify, here's why it's important clinically. The way we classify hip fractures, hips break a lot. If you have an older relative or somebody elderly, they're really scared about falling and breaking the hip. The reality is it's usually not. They don't fall and break the hip. The hip gives way because of osteoporosis and they fall. It's the other way around. I mean, could they fall and break it? Most of the time. Elderly people, you're going to see them explored in this unit and bone get fractured from called pathological fracture. That's when it's disease in the bone. Most commonly osteoporosis is a tumor root infection. Your age group, most time when you break bones, it's for an accident. Sporting. Or if you're like me, we call it clumsism. I'm an accident looking man. Like the movie scene watching TV and eating, and my wife comes over to me with a bib. I think it's like I'm a baby. She goes, she starts putting on, what are you doing? In your bib, because you're going to have your food all over your shirt. But I don't want to wear one. She looked at me and goes, you will. And I know again what to say to her. Yes, dear. Look her right in the eye. Yes, dear, you're right. Well, I've been around for these 7 years. I know how to talk to her. I can put her in her place. Yes, dear. I'll do that. Survival. Survival takes over. I was chasing a guy on the New Jersey Turnpike who cut me off and I had my bones. Okay. He didn't stop, I guess. So those are trochanters. The intertrochanteric line is something we look at. We classify hip fractures as transcervical. This is the head, okay? This is the neck. Pretty obvious what they are. There's a subtle difference between surgical neck, which is here, and anatomical neck, which is closer to this. This is the head and the neck. So transcervical, a fracture in the neck, is a fracture that generally destroys the head in an elderly person. Usually have to replace that with some type of prosthesis, some type of artificial hip, or at least part of it. While it's pain and there's a lot of morbidity, it's not life-threatening. Why? Because the capsule, the enclosure around the joint, doesn't let blood go out. It contains the blood. Intertrochanteric fractures, also very common, are relatively easy to fix because you can put a pin or screws or plates in there to hold them. The head you have a very generous blood supply, extremely in bone. That's the good news. The bad news, if you don't work right away, that person can exsanguinate. Because capsule ends here, and they be bleeding right into their tissues. That's why we do this. That's what you see in a hospital. That's where you're very specific with the description, be it an x-ray or a scan. There's evidence of an intertrochanteric fracture that's complete to some degree. If you still go over all these tests, how you categorize this. That's why the anatomy is relevant. If you're going into a field, because you'll never understand. And again, on the femur, you have a line. This line is a fancy name. It's like a ridge. And the ridge forms, I have it blue here, because you have these giant muscles in the front of your dog. They're so giant, they're vast, and that's their name. Vast is medialis, which is on the inside, lateralis is on the outside. The little one is a little bit thinner that goes into your knee joint for the vastus intermedius. And that's why when you do knee rehab, you do straight leg raises. Neck. They swing around from the front, this is the front, and they anchor in the backs, and they create that line. It's not just a line, it's called the linea aspera. I don't know what the aspera is, but aspera is line. The Latin is linea aspera. Okay. Tuberosities are large, tubercles are a bit small. Okay, so go back on the same femur here. Medial is always going to be where the head is. I don't do right and left, so you have to do that. There's a little bumpy here. That's a tubercle. It's not as big as, say, a tuberosity, okay, but it's got like a little projection of bone. It's called a tubercle. That is the adductor tubercle. A very large muscle, that's the biggest muscle in the groin, is called the adductus, A-D-D-U-C-T-U-S, magnus. So you have a longus, you have a brevis, and magnus means large. Okay? So you see that over here at the adductor tubercle. Your cartilage is over here, and feet are free for this demonstration. Cartilage, you can see the difference. You feel this bone. Cartilage, okay, is smooth. Even if bone is preserved, you can still see the transition between roughened bone and cartilage. You can see it here, roughened here, cartilaginous here. You see there's a little opening as well. So they're really important. And what happens is cartilage doesn't have anything to attach to it. But on any long bone, whether it's the femur and when it goes, when it contacts the tibia, or the humerus and either the ulna or the radius, or for that matter, your fingers or your toes. Let's look at it from a finger perspective. Something from, they're called phalanges, long bones, from your proximal, middle, and distal. From your proximal phalanx to your middle phalanx, on either side are little bumps, very hard to see and feel. They're called epicondyles. The cartilaginous covered area is a condyle, okay? And so we name the roughened areas where ligaments attach on either side of those joints as epicondyles. Ligaments like the medial collateral ligament of your knee, the lateral collateral ligament of the knee, go from epicondyle to epicondyle. have to open the knee up. A lot of times, you open your joint up, you have to center that, and it's a heavy condyle. I showed you the spine. That's a different vertebrae. That spinous process points down. That's a spinous process that we see associated with thoracic vertebrae. That's the tail, the giveaway. If you hold the vertebral body, this flat part level, parallel to the ground, okay, boom, spinous process points down. So what happens when you go to have an exam by the doctor, you bend over, those spinous processes can protrude and they can run their fingers down until what you have is disease goes. What country? And process, like I said, is any broken problem. A lot. I'm still going. That's the trouble when I've been talking with children for 3 days. It's now plus my kids, adult children, and grandkids. Now I get to talk with adults. Okay. Now joints are the oddball. Condyles again are where bones meet bones in joints. So the condyle I showed you there, those are femoral condyles or the medial. They have mated ones on the tibia. These are named condyles on the humerus. On the tibia, you see the bone roll. This is again. So if we look at it this way, this would be medial, lateral condyle on the tibia. And would be rejected medial condyles. What's interesting about those condyles is they're fat. It's not really very soft. That's where the menisci come in. Those cartilage are like little gaskets. Look at the depth and roundness. Why they're so darn important. Okay? So there, the illustration that they have up there is the jaw. So this is a jaw that comes from a different model that blue and red have muscles. That's where muscles attach or have attachments on. These, which is on this bone, is called the mandible. These are called mandibular condyles. There's a lot of anatomy comparatively on the mandible. It's the only bone in your skull that moves. Okay? So it has a notch, that's a mandibular notch. As a process, that's like I think that's a coronoid process. It has a little opening in here where an important nerve called, get this, mandibular nerve comes in, called the mandibular foramen. That's a wonderful nerve that we use in anatomy. So if we go to the dentist, then you have a cavity or after you extraction on the lower jaw, generally you can do it with one shot. If you have one of those, I've had too many. Okay, one shot back here, that's where the anatomy is important for local anesthesia. You numb that, it will numb that whole side. This will overlap on the jaw, so you don't have to do a whole one. And upper, much more problematic. Several shots to numb that area. You have to have a root canal, extraction, or explore the cavity. See, I'm happy. My teeth is easy. I can just leave them. It's like your car. Are you going to stay with your car or are you going to leave it? Are you going to wait or not? I do that with my teeth. Go to the dentist. Are you going to stay with your teeth or leave them? No, I'll leave them. I'll come back. So that's a condyle. And then you also see that, and the head. I think a better example of a head would be like this. Ribs have heads, and they have facets. Again, if you look at some of the small bones that I had talked about before, any of these articular surfaces, you would see are this. So if you're wondering, I mean, here we are with the foot. It's one of these areas, and it isn't demonstrated with the stops a pretty mangled specimen. But when you're worried about what occurred with Najee Harris, he had an injury to what's called the sphinx. And if I had a foot that was well articulated, it's right around that area. The sphinx joint is a junction of the tarsal bones and the metatarsal bones. They used to say TMJ, but people now associate with temporal. So the name that is used has been around for longer than TMJ, that has been popular now. It's called this fracture. That's an injury you don't want to have. That's natural, because your power, propulsion, start from your foot. Comes from the stability of your foot. That's like propulsion. So that's a mess. I don't know what it didn't strike me as in that game, it struck me as more like he rolled something as opposed to hurting his foot. But TJ Watt, you can see immediately like this. That's never a good sign. It's like with Roethlisberger, where the rib goes out or something. You know, he knew whether he heard it or felt it. He's like, oh, I'm certain word. I'm in big trouble. I don't know what I would. We had 4 entries in the suicide report yesterday. Now we have 1. 3 losers. So we're going into losers. Unless you're winning against the grain, I know the Steelers would lose. I thought they'd never bet Indianapolis on people. They always lose. Okay. And the Titans against the woeful Giants, they lost. No one owns the Ravens. You should put all 4 on the Ravens. You always count the chest. You should be saving that since. Just say. So cassettes, you'll see these. Cassettes are sort of a generic term, typically associated with flatter articular surfaces, which brings us to all these indentations. Sometimes they're openings, and we see a lot of them in the skull. Okay, so there's a lot of different grooves. Okay, maybe the most visible groove is here. So here's a plastic model. This is a tendon that creates, this is the tubercle and this is the tubercle. Greater and lesser because of their size. Okay, in between them is a tendon. It sits in a groove. It's called the bicipital groove, because this is the bicipital tendon. So what's called the long head of the biceps. So another sports injury that you typically see in a big one is somebody tears a bicep. The tendon doesn't tear. It kind of pops out of the groove, and the structure that's holding it in isn't very strong and over so. Put it back in over so to get it to heal. It generally takes about 6 months. That happened in the Steelers in the 05 years, the early Roethlisberger years. A guy named Aaron Smith ruptured biceps. So those are another one of those. And again, defensive and offensive line. So that is a group. Fissures, and there's a lot of different fissures. The easiest one for any student to see is here in the skull. So if you look in here, look in the orifice at the socket of the eye, it looks almost like you have a triangular design. You have a slit here and a slit here. This is called the superior, the one up top going this way, superior orbital fissure. The one on the bottom is called the inferior orbital fissure. And they don't always have to have something going through them. Understand that when we see these things, what they do with bones, when they preserve them, typically they boil them, and the temperature is warm enough so it melts the soft tissue. The inferior fissure is normally filled with other soft tissue material. It doesn't exist really, other than in a bone preserved specimen. The upper one, the superior orbital fissure, is very important. Major nerves and blood vessels go through them. That's a very significant opening. Okay, so some of these are artifactual. I mean, they're part of anatomy. So, I mean, the fact that something's there doesn't necessarily mean there's another one in the skull. So if you pop the skull apart, and look inside, we've got a whole bunch of the skull's the hardest one. I always do the skull first. It's the hardest one, it's got the most names that are associated with it. There's an opening. Oh, I came in for I spare no expense. Q-tip. Good, long. Point out these openings. So these are ones that you're going to have to know. There's a little one, these are called foramina, foramen. Something goes through it. This tiny one here is like a little spine. It's called the foramen spinosum. What goes through that is a little blood vessel. It's actually an opening for the maxillary artery. It eventually becomes a really important on the brain called the middle meningeal artery. So that's significant. Next to it is a very large opening. You can see where I'm pointing over here and here. It's oval, called the foramen ovale. There's another one with the same name in the heart. Okay, that really isn't supposed to be there. That's the one we get to when we talk about Christian tank. That is a permanent little opening they have in his heart where a lot of blood clot goes through. But he had missed a lot of that second Stanley Cup run. One reason my wife thinks he's particularly, she figures now that Tom Crusoe or wife, she's got a shot. She thinks she's got a shot. The girl who got married, she went to the University of Florida with Tim Tebow. She's hoping she has a shot. I think she missed one. It's just kind of sort of a picture of Tim Tebow that my friend's wife had done as a tradition. They had a daughter of nuts. But the point I'm making is this opening is called the foramen lacerum because it kind of looks like a laceration tear. There's nothing goes in it, so cartilage. It just shows up because the cartilage when the bone is prepared to look at it as a skeleton, that cartilage washes away and disappears. So a lot of times holes aren't holes, they're artifacts. That's the point I'm making. So you have fissures that you can see there. You have foramen or foramen you can see there. So you have fissures. Notch I showed you before, the one here. There's a lot of other notches, but that's a perfectly good example of a notch, a mandibular notch. It kind of plays a role because there's a very strong muscle called the temporalis, that's one of your muscles of mastication. So they kind of have it demonstrated there. We'll get to that when we talk about muscles. So let's work our way down. Others, meatus. Well, a meatus is more like a tunnel. Okay. So a urethra was a urethra. That's inside. Inside is your bladder, outside going out the external environment. The most famous meatus is right here. It's your ear. Okay. It's called, you have an external, and on the inside you have an internal auditory or acoustic. Either one is used in that. Meatus. So you have that opening. And then fossa, I'll do those before I do sinuses. Fossa, here, the lobes of the brain, that's little small. As they grow, they create these areas that the brain sits in. So you have the anterior, middle, or posterior fossa, the lobes of the brain that sit in. Oddball one is the sinus is a term we use a lot. Okay, in bone, like for instance, a sinus is usually a hollow cavity filled with air or maybe fluid. The ones you hear about are like your sinus headache. There's 4 bones that are called paranasal sinus around the nose. So when you guys get a sinus infection or a sinus headache, that's what it's like. As opposed to, there's also sinuses here, and the bone is behind your ears. You hear that bone. Okay? So you have that as well. That's called the mastoid process. The projection of bone, where it has sinus in there. And unfortunately, with the ear infection, sometimes they'll travel in here. People will sometimes have a mastoid neck. When you move that, because infected bone, typically you have to infected bone kind of stays infected. That's what trabeculae, all those little nooks and crannies. Infection takes them right out. So that's what sinuses are term you'll see in different areas. Sometimes it's a confluence of features. There are sinuses. It's a term that's used for different things in different places. So that's sort of the introduction on bone, on bony landmarks, kind of where they're located. And that concludes this section. I just want to introduce the bone section for a little more time, and we'll continue on. So I'm going to X out of this, as it were. And we start here with there are 3 chapters that are all about naming the bones and naming the parts. So that's the skeleton. This is the sort of the lab portion, where chapter 6 is mostly the lecture portion. So again, bone, cartilage. This is where we talk a bit about ligaments. You can see muscles are the greatest part of your body mass or weight, but the skeleton is not without a certain amount of mass. Axial and appendicular, the big divisions. The first part of this talks about the axial skeleton. So we're going to talk a little bit about the skull. I have the skulls out, and what I would urge you to do when we finish, go up and take a look at these things. Because when we have a lab exam, I'm setting those out, sometimes with illustrations, sometimes with just the bones and the models, with labels and a sheet with questions, and we effectively play musical chairs as you answer. So I don't play music, but we move chairs. It's not like we don't remove a chair when the music stops. Kindergarten musical chairs? Didn't we do that? Was I the only kid that did that? Has it changed that much? I think I was the only kid ever sent to the principal's office in kindergarten. Really? Didn't I tell you that? You had the O, S's, and U's? You remember that? You didn't get grades. You got like O for outstanding, S for satisfactory, and U for unsatisfactory. And you got those comments. You know, I got a lot of comments. I was that kid. So head, neck protects the brain, spinal cord, and thoracic organ. It depicted there in whatever that color is. So that is your core, if you will, the axial skeleton. As you can see, the connectors, the pectoral and the pelvic girdles, and all the other extremity bones are all part of the appendicular. Same in the back. Not a whole lot different. So we do with the skull. And first of all, now we've separated axial from appendicular. Next is we separate the parts of, and this is how the muscles are laid out. This is how the anatomical structures. You have 2 divisions of skull. You have a total of 22 bones. 8 are cranial. What is meant by cranial? They effectively contain the brain. The other 14 are facial. They form your face. Okay? That's a big distinction, right? So the cranial bones enclose the brain and the cranial cavity. They have attachment for the head and neck muscles. I'll buy that. The facial bones, framework of the face. Those are the openings for your mouth, your nose, your eyes are mostly made of facial bones. You'll see it's not entirely, particularly with the orbit. Air and food passage, teeth, facial muscles, typically muscles of facial expression. So not just forming words, but we all do that. You'll raise your eyebrows, you'll wink at somebody, you'll make a gesture. We use our face all the time for communication, if you will, nonverbal communication. The skull bones are mostly flat, and the only one that moves is the mandible. This is the important part. The joints are called sutures because they have a serrated or sawtooth appearance. In the old days, when they didn't have good cosmetic techniques for sewing people together, it was rather haphazard. And so typically you saw in a regular line, and that's where it got the name sutural, or sutures. And here's what they look like. They're jagged. And you can see them on any number of models. This one probably as well as any. They've highlighted the sutures in sort of yellowish color. So you can see the intro. What's really interesting about them, the horn, they are really not bone to bone. They have little fibers in them. You'll see what categorized joints, they're called a fibrous joint. And as the fibers mature, they shrink, pull together. Okay? And so if you think of a baby, babies are known to have very soft spots. Very handy for vaginal birth because it's able to shift to a certain extent to pass through the birth canal. So we name all of these, and it's interesting they go along with, and you might remember my discussion when we met 2 weeks ago about planes. This is called the sagittal suture, because it follows that sagittal plane. This is called the frontal or coronal suture. It follows that frontal or coronal plane, not quite in, but the same direction, so to speak. This one in the back, we could call it occipital, but it has the representation of the upside down Y, which is Latin, where most of it started. That's that Greek letter, not Latin, Greek letter lambda that you see, let's say, in a fraternity sorority. So it's like an upside down Y, you have a stem from the sagittal, and it breaks off into two areas surrounding it, which will come to know as the occipital one. It's called the lambdoidal suture. And the one that it kind of is an oddball, it sits a little bit, kind of sits, kind of wiped out over here. It's called the squamous suture because it looks a little bit like a squamous cell, and really it wasn't so much like this, it was really overlapping. Squamous kind of means so it had a little degree of overlap about its name. What they all have in common, the bone that is here, the side of your head, that makes up the sagittal suture are called the parietal bone. All sutures have some way, shape, or form. The parietal bone is part of it. Frontal, parietals. Parietals, occipital. Parietals, temporal. So that's where the sutures come from. When they're not together and it's soft, sometimes we'll get fluid that will occur in them, and they will outpouch. So the old anatomists thought they were fountains almost, but they were little, so they used diminutive suffix, fontanelles, like organelles, fontanelles. So that's what some of the things we see. The last one to close is the fontanelle that's here, between the sagittal and the frontal, that particular, that close to that H2. And over time, like I said, it closes as the fibers grow closer together. So that's kind of what you're seeing. So the bones that form, we'll look at the cranial bones ever so briefly. So you have one frontal upper parietal. Parietal is here, so you have two. Occipital, one. Temporal, two. So that's total 6. Only 4 names. Then you have 2 more. Ethmoid, sphenical. I'll put a star or an asterisk next to those. Why? Those bones participated in the orbit. So there's 7 bones, 3 cranial and 4 facial that help to make up the orbit. You have to know those bones. Don't thank me. I'm terrible. You know, I actually have fun doing this. My wife wonders why. No, she doesn't really wonder why I don't retire. She'd rather because if I was retired, I'd be at home. She doesn't want me. So the cranial vault that I showed you before with all those fossa, another name is calvaria. I don't use it. Okay, the fossa I showed you, I don't really, not a big deal to me. There they are, all those wonderful, and there's lots of holes, and they all have names. So you can see the lobes of the brain that cause this, whether it's frontal or the anterior, temporal, and this piece of brain, piece is the wrong term, this portion of brain It's called the cerebellum, really important. The cavities, 85 openings. There's a lot of these, and that's, if you are doing A&P, that the nursing students do, I do a few of these that are major. For you, we do a lot more. That's the distinction between advanced anatomy versus standard A&P. You know, that's what you're in here for, to know this type of stuff. So there are the cavities that you saw before. We'll go over the different bones that are part. It's a pretty useful schematic, I think. Frontal, parietal, occipital, temporal, sphenoid, and ethmoid. I drew that very same thing. Beauty of these is there's not a lot on some of them. For instance, the frontal bone doesn't have a whole lot of anatomy. I don't have a separate one. If you look at any of the skull models, it's really the forehead. It provides the upper margin, so to speak, and sort of this undersurface of the upper portion of the orbit. The brow, and you see how it kind of protrudes a little bit if you sort of run your fingers down? That's called the supraorbital margin. Supra, above, orbital, eye socket. A margin is like a ridge or a supraorbital ridge. So it's kind of underneath your eyebrows, okay? Most of the anterior fossa. There's a little notch. You sort of run your finger over here. You can kind of, as you run along your eyebrow, sort of from the medial aspect, you know, to your nose, you kind of get a little indentation that's over there. We all kind of have it. And there's a little artery that comes through there. I don't worry about that. In between them, they call this the glabella. I could care less. Okay. Frontonasal suture, not a big deal to me. Okay. So all of those, to me, the supraorbital margin is the most significant portion of this. So as we look at it, it's kind of here in that little notch or ridge. Okay. So it really is a substantial. Frontal means forehead, and as you can see, and the colors are useful. That produces a significant part. I have a lot of this on a handout, or it's kind of like a study guide for our bones practical. So I'll get that printed or sent to you if I remember it soon. So kind of, again, that's that whole yellow area that's here. This pink one, not going to do today. That's the sphenoid. This one, probably not going to do today. That's the ethmoid. Sphenoid and ethmoid are very much more complicated. I'll try to get the other ones in. Moving along. Another view of the same thing. The parietal bones, other than the fact that they form the sutures, there's really no anatomy. There's not a lot to them. You don't have big muscle masses that attach to them. There's really not much of them. They just really form the sides of your skull, for lack of a better way to express it. They don't participate in the orbit. They're just there. But they do make up the sutures. And you can see that discussion here. You saw that illustration before. So here's that sagittal suture. There's the parietal. Yeah, there's some other ridgy type things. They really don't have names. So when you get back here, that we begin to get significant changes, and that's the occipital bone. So the parietals are paired, and here you have that sort of brownish color, sort of lighter brown than the darker brown of the occipital, is you have the temporal bones, which are paired. The occipital bone has a lot more anatomy, not all of it major. For instance, a lot of your head is supported from the back. Okay. Your neck area has muscles and ligaments and tendons in the back whose job is to hold your head up. Okay. There's a tremendous amount of strength in the anterior portion. In the front, it's very soft, it's very open, it's access, and you have vital structures, major arteries, nerves, veins, respiratory structures, digestive structures are all there anteriorly. So that's why, if you didn't know, when you have to do surgery on cervical area, on the neck, you don't go from the back. They used to. Now we go from the front, because this stuff is all easy to move to one side or the other. Even if you're doing an operation on a cervical vertebrae, your access is from the anterior aspect. Posterior is just, there's just too much stuff in there, comparatively speaking. So which brings us to these little extra pieces of bone we don't all have. That's why that 206 is sort of a general number. This is, sutural bones are little extra pieces of bone that might complete the suture. We have little bits of spare bone in different areas that are useful. So these ridges that you see here, whether it's the supranuchal line, because we call that strip of like tendoligamentous structure called the ligamentum nuchae. It's a strip of what's called aponeurosis. Back here, you have the bump on the back. It's called the external occipital protuberance. So you have a lot of those, but really it starts to get important with three major structures along here. You have somebody that's on it. This is kind of what it looks like. That's an occipital bone. How do you know it's an occipital bone? It's not. It's one thing that tells you what it is. That is foramen magnum. That's magnum means it's the biggest. It's under magnus. The foramen magnum is the biggest opening that we have, really, certainly, in the skull. What passes through there? Spinal cord. That's where the brain stem is on this side, where it goes through the foramen magnum. Actually, it's spinal cord. It's kind of like Pennsylvania Turnpike to the Ohio Turnpike. They're similar, except you get to Ohio, the road's there. It's not all turned on the right to south. Right? Tell me I'm not right. I mean, is there a road in Pennsylvania that isn't under repair? Ever? It's ridiculous. I live in Cranberry Township. They do working on that overpass, 79 Turnpike. Oh, God, forever. I live right here. Oh. Again, I'm from New Jersey originally. We don't have this. Just, what's going on? I don't know. So, we move on. So we have the foramen magnum. That's a significant opening that you all have to know. Lord knows that's on the test. You're wondering why I'm making a big deal of it. It's on the test. Not done yet. On either side of the foramen magnum, there are condyles. Sometimes we name condyles from the bone they're on. Sometimes we name structures for where they're going. These we name from the bone they're on. They're called occipital condyles. They sit, interestingly, here. I'll get it out when we do the vertebrae. The first cervical vertebrae is very unique. It's like a ring of bone with two very, very large sets to form this joint. Okay, it's got a fancy name. It's called the atlas. Okay, atlas was atlas holds up mythology, holds up the globe. Okay, it's called the atlas because it holds up the skull. The occipital condyles are rounded; they're convex. Condyles that receive it on the atlas, the first cervical vertebrae, are concave. So it allows you to do this, and to a certain extent, a little tiny amount of motion side to side. Okay? So it kind of makes a very interesting joint. We call contour joint. It moves in these two directions. Okay? They're important, but we're not done yet. On either side of that, if you look, there are two little holes. I'll kind of show you where it's going by doing it this way. Comes like this, it kind of comes out this way. So it's going forward. So you can see the little opening in there. It's a canal. It's called the hypoglossal canal. Glossal tongue. Hypo below it. So the nerves, 12 cranial nerves, we're going to get to it part of the program. Well, the hypoglossal nerve is the one that helps you stick out your tongue. used for chewing movie or something. And it's the only time I get a chance to stick my tongue out. That's where it comes from. So we kind of get a directionality from that. So the big structures here, not so much the prominence of the nuclear lines, which are here, better seen on the illustration, but the occipital condyles, the hypoglossal canals, and certainly the brain pattern. And then other bones, part of these are a bone model. I'll try to find it. They're very, very fragile. It's called a temporal bone. Temporal bone is the bone. So I'll kind of show you where this is the left. So if you have glasses, the size are full temples. Temporal bone is here. It's a rather interesting and oddly shaped bone that really has a fair amount of anatomy. It actually, in classic anatomy, I don't go into it, it has 4 different regions. Okay, it has the squamous region that's here, which is that long shelf that forms what I described as that squamous suture. The mastoid region, with that mastoid prominence, which is behind. So it kind of sits like this. It has inside, because it's bony, harder, they call it the petrous or petrous region, hollow petrified forest. And you have the auditory region, which is here, where the auditory meatus is located. Effectively, that opening of the meatus is covered by a very significant structure, tympanic membrane, or eardrum. So it's intimately associated, you might guess, with hearing. There's a lot that goes on. You have a lot of anatomy. You have 3 different processes, major. This one is called the zygomatic process. Sometimes we name processes for where they're going to. I have one in here. I just find it. I'll scoop it out next time if you don't see it right away. It's called the zygomatic bone. It's really the bone here on the side of your organ, what we might erroneously call our cheekbone. You can feel it here, the zygomatic bone going backwards into the zygomatic process. It has a temporal process on the zygomatic bone, which we already saw. The zygomatic process is going toward the temporal bone going here. Together, they create this structure, which if you see it on a model, to the left of them, right there, here's the zygomatic bone, here's the temporal bone. This is called the zygomatic arch. Through that area, that muscle I mentioned before that helps you chew, tympanic muscle, okay, because I beg your pardon, the temporalis muscle goes through that. Very important. It's got a little spike. You can't feel that. It's surrounded by muscle. It looks like a little stylus, like an old-fashioned that you think with a stylus. You might use that. You had the old types of tablets. They had a little stylus that you wrote with, sometimes like that. It actually goes back to the. You remember cuneiform writing? They used the stylus and stone, and they like those look like room, like different kinds of movement of language. According to rooms, was sort of Middle Eastern. I'm a fountain of useless knowledge. Anything up to 1980, I got it covered together. Anything past that. Huh. Lastly, you have this process called the mastoid process. They surround the auditory meatus, which is there. We're not done. This is the external auditory meatus. You guessed it. There's an internal auditory meatus. It's a tunnel, meatus. It's like going from, you're going over the Liberty tubes. We have a lot of tunnels around here. Well, I grew up in tunnels when we were underwater. Here they don't do it. We have Holland Tunnel, Lincoln Tunnel. We went to Midtown Manhattan, went down to the Lower East Side over Brooklyn. People used to know a lot. So that's the internal meatus. Not done yet. Between the mastoid and the styloid, you have a little opening. It's a foramen. Putting my marker in there. It's called, guess this, complicated. The skylo-mastoid foramen. It's named for the two structures in between. Why am I mentioning it? A very important nerve, called the facial nerve, exits there. And what's in close proximity to that, okay, is the temporomandibular joint, which is up here. Okay, this is called the mandibular fossa because it receives. Oh, no. Hey, it kind of sits like this. Make sure it's not accurate way of doing it there. We're kind of like this. Okay? So that's if you can see kind of where the stylomastoid is, right behind it, the nerve is the facial nerve. It's the nerve. So sometimes when you get temporomandibular joint dysfunction, you learn why that occurs. You get some problems, let's say with some of the facial muscles. It's a very, very, very famous disorder. You probably know somebody had Bell's palsy. It occurs rather easily. It doesn't necessarily have bad outcomes. Just go push on it. It's all paralysis. You can get it from cold or facial. That effect, and that's why that's important. So that's covered in cartilage. That's a very interesting joint. There's a lot of motion. That has another gasket like the menisci. That's why you have temporomandibular joint dysfunction. They've got a little gasket because not only does this move basically up and down, it also moves side to side and front to back. Because that gasket. The more stuff you have in a joint, the more stuff can go wrong. Your knee is a poster child. It's got ligaments, it's got cartilage, it's extra cartilage, and ligaments inside, ligaments outside. So that's what happens. There's a lot of anatomy associated with these structures. Interestingly, the nerve that you hear with the acoustic nerve, which is now called the vestibulocochlear nerve, it's two nerves you're hearing now together. It enters here, it doesn't exit. It's the only cranial nerve that doesn't leave the skull. It ends inside the cochlea for hearing, something called the semicircular canals. That's what all this is leading to. So I have a sheet rather than write all that down in my handwriting. Those are basically a summary of those first four. My voice is going to go, so I'll save the ethmoid. First of all, I don't have a good ethmoid. I have an illustration, and I have an okay speed point, but the illustrations do better. There's more anatomy on those. So we'll leave it here. And so if you want to come up and take a look at some of these bones and answer any questions, feel free, or all of them. And if we're going to next time we're going to get involved with identifying all the structures on the bone.